to our very first CPD event for the academic year 2022-2023. I hope that each and every one of you has had a restful summer and spent time with your families and friends and enjoyed the warm sunshine that we are so blessed to have here in Ontario. I'd like to take a moment to think about the families and the victims of the tragedy that has taken place in Saskatchewan. So if each and every one of you can spend maybe about 15 to 20 seconds just thinking about them. All right. So thank you. We'll start off with the land acknowledgement first. We acknowledge that the land on which we are gathered is the traditional territory of the Anishinaabe, Atawandron, Wendat, and Haudenosaunee peoples. This land is covered by the Upper Canada Treaties, and we are here in peace and walk with respect on this part of the Turtle Island. It's my pleasure today to introduce our two guest speakers, Dr. Robert Nicolson and Dr. Ashan Veerakumar. Dr. Ashan Veerakumar is a fourth-year psychiatry resident here at the Schulich School of Medicine and Dentistry. He has completed 7 months of his child psychiatry rotations and electives. 4 of these months were supervised by Dr. Robert Nicolson, and they were focused primarily on the care of children and adolescents with developmental disabilities. Dr. Veerakumar is interested in pursuing a career focused on the care of individuals living with moderate to severe neurodevelopmental disorders. Dr. Robert Nicolson is an associate professor in the Department of Psychiatry and chair of the Developmental Disabilities program at Western University. Dr. Nicolson completed his medical school at Western University before moving on to the University of Toronto to do his residency in psychiatry. He worked as a visiting scientist in the child psychiatry branch of the National Institute of Mental Health in USA before returning to London. Dr. Nicolson is a child psychiatrist whose practice is largely devoted to children and adolescents with autism spectrum disorder and intellectual disability. He's a psychiatrist in the Developmental Disorders program at Children's Hospital at London Health Sciences Centre and in the Autism Spectrum Disorder program at the Child and Parent Resource Institute in London. Both our presenters will be talking on the topic of autism spectrum disorder. How far does the spectrum extend? Please join me in extending a welcoming applause, virtual applause to both of them to join join us for today's presentation. Our presentation will start with Dr. Ashan Veerakumar, who will be starting off today. So welcome, Dr. Veerakumar, to today's podium, and the podium is yours. Thank you.
Okay. Thank you, Dr. Dua, and good morning, everyone. Thank you for attending this presentation. I hope you find it interesting. As mentioned, I've spent several very formative months working with Dr. Nicolson. It was a great pleasure for me to learn how he approaches these cases, and it's a great privilege to offer 2 cases that I remember quite vividly from my time working with him, and hopefully they will be a decent contribution, if possible, to his presentation on autism spectrum disorder. So firstly, there are no conflicts of interest to declare on my part. The first case, we will call him RJ. By the way, I have de-identified the name and also the age, several details to try and preserve his anonymity while retaining some of the essential elements of the case. But to carry on, he's a 12-year-old male, grade 6 student, EA support, living with his mother. He has scheduled visits from his biological father. He is very well known to LHSC, mood disorders, and trauma attachment teams. He's a long-term patient of theirs for continuing behavioral concerns. He was referred to for an ASD assessment on behalf of patient's mother. So what I mean by that is technically, as you all likely know, the referral comes from another doctor. It does not come from a specific person, but I do think it is worth understanding also where the referral is coming from. And what I'm saying here is that the doctor themselves, the medical team themselves were a little skeptical of ASD, but the mother was more concerned about ASD. And that's what I mean by that statement. So to go into the history, per RJ's mother, she described him as being the best child until he began his foster placements. And according to the trauma attachment team, there were several foster placements. If memory serves me right, there were over 5 in his young childhood life. And at one point, there were reports because police or CAS had to visit for another reason of some kind. They found that he had been in a high chair on his own for several hours, alone just with a TV, and that this had happened quite often. So not your average neglect when I mentioned these foster placements. Despite what he had gone through, the teacher reports were a bit conflicting from the mother's reports. They are concerned about hyperactivity and school progression, but they also described him as a social butterfly and a ray of sunshine. RJ's mother discontinued psychotropics for ADHD and also discontinued antipsychotics prescribed for behavioral dysregulation. Her opinion was that since RJ could focus on a few preferred play activities such as Lego, in her opinion, he did not likely have ADHD. She did hear from a friend about ASD and then began advocating for this diagnosis and was appearing to refuse all psychotropic interventions until her concerns about autism were investigated further. And it was in that context where the ASD team were clarified. The mood disorders team tried to reassure her that RJ did not display too many signs of autism from their perspective, but due to the persistence of her request for another assessment, we were consulted. To speak a bit further about the history, when she discussed his behavioral triggers, a few interesting points popped out at me. She reported that once he was in the pediatrician's office and the pediatrician made a comment to mom, in a kind of joking manner, like, oh, with all these behavioral concerns, maybe we'll have to try an overnight camp. And then when RJ heard about potentially going to another overnight camp, he became verbally and physically aggressive. And as I was doing my usual review of systems questions, which include asking about worries, his mom mentioned that RJ would consistently voice worries about CAS and being taken back by CAS. When asked about what she would prefer more in her in RJ's clinical care, she mentioned that she was quite overwhelmed and she desired more services. And when I followed up further to ask whether she wanted autism services or any other kind of services, she just said any more services would be much appreciated. So on examination, when we saw RJ, we noticed that he was dressed in pretty worn and baggy clothing and with noticeably dirty fingernails, definitely more dirty hands than we would normally expect with individuals of his age. We did not observe any tics or stereotypies. He quickly made eye contact when called and said hi when his name was called, and he was quick to break eye contact. And I want to highlight that because sometimes people may have a lack of eye contact for multiple reasons. Some people will avoid eye contact, and often they will make eye contact but quickly break it. But if you don't notice them making eye contact quickly, you might think they have no eye contact. In contrast, in some of the even high-functioning autism cases I have observed with Dr. Nicolson, if they make eye contact with me, it's pretty much a statistical fluke. It's just that their pupils happen to meet mine for just a brief second. And it's almost as though they don't notice that there are eyes on my face, while others are trying to avoid my eye contact as much as possible, which is different. With regards to his speech, he used his words to express himself and appropriately integrated nonverbal gestures. He did have several grammatical errors that I wouldn't expect for neurotypical individuals of his age, but he did not have any I versus you pronouns reversed. And all that to say, he did not exhibit any immediate or delayed echolalia that I would expect in autism. He would fidget often throughout his assessment and even leave his seat, if I remember correctly. But I also observed that he was able to be redirected to a cooperative play activity with one of the clinicians. So for the assessment and plan, after we saw him, we did agree to do an ADOS assessment to follow up and to do a debrief with the mood disorders team. So the mother would see a bit of a unified front if we found no autism, which we expected. We agreed with the prior ADHD, learning disability, and unspecified trauma stressor-related disorder diagnosis he had. And by this, I mean he could have persistent reactive attachment disorder, disinhibited social engagement disorder. And I believe he was also diagnosed with disruptive mood dysregulation disorder. So we agreed with the prior diagnoses, and we assessed that, at least at this point, it was exceedingly unlikely that he had autism due to the quality and number of social overtures observed during the examination, even if, according to his mom, they were less so at home. And also, we based this assessment of no autism based on the lack of observable stereotypies and ritualistic behaviors. And this last line about the stereotypies and ritualistic behaviors is quite important to keep in mind when observing a patient who likely has reactive attachment disorder, because some with such profound neglect don't have the social learning of what love and attachment is compared to someone with even average levels of neglect or no neglect. And sometimes the only way to tell whether they have autism is to observe how they play. Do they engage in imaginative play, in which case they likely don't have autism? Or do they seem to fixate on one part of the play object or a way of playing repetitively, in which case it's more likely to have autism? But the child may likely have autism, but still it's a very challenging diagnosis. And it is the stereotypies and ritualistic behaviors that can sometimes clinch it in those challenging scenarios. So for the next case, there's an 8-year-old male living with his parents and 11-year-old sister. He attends school for half the day, and he has EA supports included, educational assistance, even for the half day. And he's attending the half day because of his behaviors. He was referred for an ASD assessment on behalf of the school's principal. So again, that is to suggest that the concern for ASD has come from the principal. So for the history, the parents say that he both met his milestones, but also responded very well to their problem-solving approaches that seem to work with his neurotypical older sister as well. However, they said that the school seemed to have consistent concerns about the patient that they didn't have at home. They noticed that he was sent home from daycare for aggression. They are also concerned that he doesn't make friends very easily and is not being invited to many parties. So for example, they say that he's able to easily initiate social interactions, but if the play activity doesn't seem to go his way, he tends to get upset. And for that reason, he is not really developing many strong friendships. In elementary school, there were further incidents at school. For example, the teachers actually had to tell his father to come to school every day just to bring him from the jungle gym to class after recess because the teachers were unsuccessful. They also noted that he once climbed the school fence and ran onto the train tracks, and the teacher had to run out and get him. And they also noted that if the teacher persisted in trying to focus him on schoolwork, he at some times would trash the classroom. His parents and teachers agree that this is likely ADHD. In fact, the mom had ADHD herself. Mom did not agree with stimulants at this time because she had a bad experience on Ritalin. She said she got agitated when she herself was prescribed for ADHD. So she wanted more opinions before the patient would start stimulants. Despite the teachers and mom not being very concerned, the principal heard an offhand remark that SM the patient may have a distant relative with a developmental disability. I think it was Down syndrome. And for that reason, really pushed that the parents get an autism evaluation, which they complied with. For the examination, this was done over Ontario Telehealth Network, OTN. Some striking things that I remember is that unannounced, the patient entered first we were interviewing the parents, and unannounced, the patient entered the room and immediately pointed in the direction of the camera and announced that there were other people besides his parents in the room. And I don't know about all of you, but sometimes when I'm on a webcam setup, I sometimes forget to look at the webcam itself, and I tend to look more at the screen. So sometimes if I'm pointing, I may be thinking I'm pointing to you, but I'm really pointing at the screen. But the patient clearly pointed directly at the webcam, pointed as though he was pointing directly at me, and announced that there were other people in the room. He also had no tics or stereotypies. He was able to use his words to express himself, and he was able to integrate nonverbal gestures. And he responded appropriately to questions and would speak at length about about what he liked to eat, but also liked to talk about how he felt he was stronger than his older sister. And at one point, he actually asked his parents to grab the webcam and point it at him so we could all observe him lifting an ottoman. And then as he lifted it, he would say, "See, look at me," to try and get the clinician's attention towards what he had done. So based on all of these, and really kind of after a few seconds of observing him, we were quite clear that he likely did not have autism. There was a lot of social overtures, and there weren't many stereotypies or ritualistic behaviors. We felt that he was in fact quite disabled from his ADHD and perhaps a learning disability. Disabled in his ability to make friends and progress in school because of his really strong hyperactivity. I didn't say it the last slide, but I did write it. He just could not sit still during the assessment. Nonetheless, we agreed to consider an ADOS assessment and have a debrief session with the principal, who seemed to be most concerned about the diagnosis. We provided information on stimulants, showed that the risk-benefit profile has improved since Ritalin with the longer-acting drugs, and we requested further school records and a psychoed assessment to rule out learning disability. And I'll say that for each of these cases, I've only presented the first part of the assessment. There were ADOS assessments for both of them, and they substantiated our assessments that they did not have autism. So without further ado, thank you for your time. And Dr. Nicolson said, leave them wanting more. So that's very easy when he is next. So I believe there may be a Q&A session, but it'll be Dr. Nicolson next after me. Thank you all for listening.
Dr. Nicolson, are you going to entertain questions now, or?
I think if there are questions for Ashan, by all means, yeah.
Yeah, okay. So audience members, any questions for Dr. Veerakumar, please go ahead, either post them on the chat or on the Q&A, and I will be able to ask on your behalf. Or if you do want to ask a question, raise your hand and Kate will make sure that you're able to do that.
Dr. Nicolson has a question.
All right, Dr. Nicolson, you go ahead and ask the question.
Thanks, Ashan. That was a really great sort of presentation of those two cases. I think brings up some of the stuff that I hope to talk about this morning. But in your sense, what was it that was driving the question about autism? Like, do you think it's that the parent or the principal didn't have a good understanding of the condition, or there was some other purpose? Like, what from your sense, and I don't know if we would ever get a clear answer to that, but what was your sense of what was driving the question?
Yeah, that's a great point. And of course, I'm in a general psychiatry residency, so I also see adults and transitional youth who are trying to self-diagnose themselves with autism or high-functioning autism. And I have to say the reasons, at least in my opinion, are quite different between the younger folks and the relatively older ones. So for these individuals, the context, it seems to be the mother for the first patient and the principal in the second case. They seemed quite overwhelmed with the behavior, the degree of behavioral discontrol observed, and they felt exhausted and they were looking for other answers. And I think they made the logical leap that if it is this bad, it's got to be something else besides ADHD, which seems more common. And so I've been thinking in those cases, and their lack of understanding of what autism is, and all the discourse around high functioning autism, and perhaps also other kids who may have gotten inappropriate services for high functioning autism will serve as a template for these kinds of concerns going forward. But for the older folks, it often comes about in times where they're trying to find their own identities. Sometimes the mentalization from a personality disorder or a psychodynamic point of view is impaired. And from that standpoint, they don't understand social relations very well, and they latch on to social media figures or celebrities who have self-diagnosed themselves with autism. So those are the varying contexts across the age groups that I've seen people talk about high functioning autism.
And so from what you recall, how was the statement that these kids didn't have autism received?
Right. So fast forward to if we think about the second case, we did do an ADOS assessment, and you were very generous in letting me lead the debrief for that one. We were able to speak to the principal, and the principal was actually kind of receptive after we presented, on your direction, we presented all the findings that we observed and validated the concerns that they had, and then mentioned how these did not seem to fit with the classic autism spectrum disorder features. I was not present for the discussion that yourself and the mood disorders psychiatrist had with the first patient. But I do remember the mother being from her own complex trauma history, being a very irritable and guarded historian. So I'm not sure that discussion would have gone well. But I wonder if it did go well if she got more services, which she wanted.
Oddly enough, I think that in sitting down with the mom and sort of talking at length, and there were other people there as well who had known her, I think that we talked quite a bit about, what autism is, what it's not, but also how, for many people, ADHD can be a pretty debilitating condition. It was received much better than I thought it would be, which was nice, and it makes it a lot easier, that's for sure.
Right. Yeah, and it goes to show sometimes how sometimes with the second or the third assessment, there's some validation just from all of that may have played a part. I don't know, but that's very encouraging too. So I see some.
There are two questions. There are two
Yeah.
questions. Yeah. Okay. Yeah. Go ahead, Dr. Veerakumar. This first by Dr. Michael Warren. He says, maybe I missed it, but was there psychoeducational testing with the first case and any concern regarding intellectual disability? At age 12, I thought they would be able to express some of their fears on their own. Was there any suspicion of ASD if the testing was done?
That's a good question. Memory escapes me if there was psychoed testing, but if I recall correctly, I think the psychosocial history was so complicated that they couldn't end up getting a psychoed assessment, or even if they did, it was seen as quite unreliable. Sometimes the participation is so low that it's hard to gauge what the results are. Although someone who's seen enough psychoed assessments could read between the lines sometimes. I will also say sometimes that there are some psychologists who are doing the psychoed assessments who will still maybe diagnose autism or high functioning autism, not in the way that we would. And it sort of begs the question whether whether financial incentives play a role, because they get a fee for each of these assessments. And if the parents are kind of asking for them to consider autism, I wonder if that plays a role. But of course, we cannot verify that.
Next question is from Carrie Stevenson Lim. Question is, if you thought there might be a learning disorder that has not been identified, did you find the education system would respond more quickly based on the outpatient psychiatric assessment recommendations, or did they go on a regular school psychoeducational assessment waitlist?
Oh, wow, that's a great question. I don't know how well I'll be able to answer that, but what I can say is that we did disclose a suspicion of a learning disability, and they seemed receptive to beginning that workup process, assembling the achievement scores and considering a psychoed assessment to where they can then see how the intelligence measured is different from the achievement results. But of course, where they end up in the system of how their care is prioritized, that's a very complex one that I don't know how best to answer. It seems very situation, context specific.
Yeah, my experience, Ashan, has been that our recommendations have almost no implications for what the school board does. And in fact, I think in part because of COVID and the fact that psychologists couldn't go into schools to see kids for such a long period of time, I have had parents tell me that principals have asked if we can do testing at CPRI or here at LHSC for kids because of the long waiting list for psychological assessments.
Okay.
But I think the short answer to Carrie's question is that no, I don't think it's made any difference whatsoever.
Thank you both, Dr. Veerakumar and Dr. Nicolson. Another question from Dr. Dennis Curry. May have missed this, but was there any pertinent psych family history in the second case?
Yes. Mother had ADHD, and there was a distant relative with Down syndrome, nothing else.
Okay, thank you. Those are the only questions we have on the Q&A. So if there are no further questions, perhaps we can move on to Dr. Nicholson's presentation. And thank you, Dr. Veerakumar. That was awesome. And you said you will be staying back for the Q&A part later on. So thank you very much. Please join me in thanking Dr. Veerakumar for a very excellent presentation with a virtual round of applause. Thank you. Dr. Nicholson, the podium is yours.
Thank you. What is a virtual round of applause?
A virtual round of applause is people can use the, where those
right.
reactions button is. They
Yes.
can do the clapping, and any comments that they want to make, they can actually put on.
I'd forgotten about that. I cannot find the thing to share my, oh, here it is, sorry, at the bottom.
We can see it. All you need to do it is put it in presentation mode.
Just have to embiggen it.
Yeah, no. At the bottom of your screen, you should have a little. If you go at the right hand, it's in presentation mode. Yeah, Go ahead. Thank you very much.
All right. Well, thank you, Ashan. As Verinder said, I mean, that was a great introduction to the morning. A couple of very complicated cases. And so the title of my talk today is Autism Spectrum Disorder, How Far Does the Spectrum Extend? And I would say that, what I'm going to present is not necessarily the truth, whatever that means. It's more that it's some thoughts I've had about what has changed with autism over the last 30 years. Why has the diagnosis increased so much? Why is it that we have parents and principals asking sort of parents to seek out that diagnosis, and what's really changed? And hopefully more as a way of starting a discussion about this amongst everybody. So I have the only financial interest I have is grant funding from several agencies. I don't have any personal financial interest in any of these things. So, all right. So we'll talk about these topics today, epidemiology of autism and how it's changed. Why getting a diagnosis correct matters, and what makes it hard, particularly in autism. So this is a graph based on data from the CDC and the most recent surveillance report for autism in the United States, which was published in December 2021. It includes up through the year 2018. And we can see pretty dramatically that the diagnosis of autism in the United States has increased remarkably over the last 30 years, from roughly 1 in 1,000 to, I think most recently, we'll see in a second, is 2.3 per 100, right? And that's a huge change in terms of prevalence rates, and how do we account for it? And I think there's absolutely no question that this is correct, right? That there's no doubt that more people are being diagnosed with autism. I think the question for us is really, how do we account for it? Is it some kind of biological change? Are there external factors that might account for this, or are there other things? So based upon that study from the CDC, what they found was that, and I think they look at it's 8-year-old children, and I think they have 20 sites across the United States. I'm not sure of the exact number. And so they found the prevalence to be, 2.3 per 100, or 1 in 44, which, given that we used to say 1 in 1,000, 1 in 44 is a pretty dramatic increase. And the male to female ratio has always been around 4 to 1. A little more than a third of people with autism were also diagnosed with intellectual disability, and we know that people with autism have a higher rate of seizures. So these, again, are not debatable numbers. These are what epidemiological studies have found most recently. I think the question is, how do we explain that? And so this is a bit older data, and it's a bit confusing, but what they found was that in Minnesota, and they have a fairly good surveillance system there, is it not only, so for people within the same birth cohorts, we have 3 birth groups here: people born in 89, people born in 91, and people born in 93. And you can see that for all of them, as people get older, the prevalence increases, right? So from the age of 6 to 11, the diagnosis, the prevalence in people born in 1981 increased from 13 per thousand, 1.3 per thousand, up to 3.3 per thousand, right? So that's a pretty significant increase. And given that autism, at least as it was originally conceptualized by Leo Kanner, was a disorder of early childhood, or at least recognizable early in childhood, it's a bit difficult to explain why it would be, the rate of diagnosis will be almost tripling, or the prevalence will be tripling as people get older. The other, and we see the same things for other birth cohorts. And what's also interesting, though, is going across different birth cohorts. So when people were 8, it was 20 in 10,000, then 35, and then 66 later on. So it's increasing both within birth cohorts and across birth cohorts with age and things. So question is, actually, sorry, I shouldn't have said PDs. Why is the rate of autism increasing? And I think it's a really fascinating sort of question from many perspectives. So one possible explanation is that we are using very, very different criteria. And so in some ways, there's no doubt that the rate of diagnosis has increased, but whatever autism is, has that actually increased? Because in some ways, we're actually comparing apples and oranges. And the criteria have been broadened recently in the last 20 years to include people who are more mildly affected, who would have been felt to not have autism in the past. So if we look at the change in DSM criteria over the years, well, actually, sorry, this is a Magic the Gathering card. And this is basically how, in some ways, how DSM criteria are created, right? There's a group of people who look at research data, and based upon field studies and things, they come up with ways of looking at the criteria and changing them gradually or radically. And so it's experts' best opinion about what the actual criteria for autism are. So in 1980, it was defined. This is when autism first showed up in the DSM, and it was sort of very narrow. However, it was also very hard to operationalize. So, pervasive lack of responsiveness to other people, gross deficits in language development, unusual speech pattern, and bizarre responses to various aspects of the environment. So, and I think the group of kids that this was defining or diagnosing was sort of very, very narrowly defined autism, the way I think Leo Kanner had conceptualized it, and sort of perhaps more what we might call it more classic autism. DSM-3 in 1988 is when the sort of buffet style of diagnosis of autism became more apparent. So out of this list of 16 criteria, I had to have 8 of them, with 2 from column A and 1 from column B and 1 from column C, and then another 4 to add up to a total of 8. And so when DSM-4 was published 6 years later, that trend sort of continued. So we have the same sort of 3 groups of symptoms as in DSM-3 are listed in DSM-4, with the qualitative impairments in social interaction, impairment in communication, and then restricted and repetitive patterns of behavior. What has happened with DSM-5, although it uses the same approach, is that I think studies suggest that really there's 2 factors, not 3, because the communication problems are really social communication for many people. And so rather than having 3 groups of symptoms, there are now 2 that people have to meet the criteria for. And it's now so there are now 3 symptoms for the sort of social communication deficits that people have to have in order to meet the criteria for autism, or at least have to have by history. And each symptom, I think, really should be impairing in and of itself. And restricted and repetitive patterns of behavior, and you have to have 2 of those. I mean, personally, I think one problem with this current definition of autism is that it is the hyperreactivity to sensory input. And that I think that is a really non-specific symptom, and it's seen in many, many conditions, I think, probably across the board in child psychiatry at some level. And I think that just creates more difficulty. But so what we can see, though, is that from DSM-3 to DSM-3R to DSM-4, and now DSM-5, and now even the revision to DSM-5, the text revision, that the diagnosis of autism has changed fairly radically with each iteration. And I would venture to guess probably more than any other psychiatric diagnosis, it's changed. And I still don't know if we have it right. I went to a talk a number of years ago by Catherine Lord at an autism conference, and she was saying that, you know, what we have done repeatedly is we've come up with lists of things that children of autism things that they should do that they don't do, and lists of things that they shouldn't do that they do. But it really hasn't worked out, and it's not been easy to distinguish that from other conditions. And so the way I think about it is the way Justice Potter Stewart in the United States Supreme Court once described it. It's a court case about whether a movie was obscene or not. And what he ultimately said was that, you know, he couldn't sort of really define what was encompassed by the description of hardcore pornography. But and he says he never could, but he knows it but he said, I know it when I see it. And I think in some ways that is what we have with autism, right? I think it's really, really difficult to define operationally what these social deficits are, especially in the more severely affected people. And yet I think it's very recognizable. I was talking a few weeks ago with Evdokia Anagnostou from Holland Bloorview in Toronto, and she made, I thought it was a really good point. She was saying, you know, that in kids with classic autism, the ones who I think we can all recognize, they are very recognizable very quickly. But if we stop and think about what is it that makes them so recognizable, I don't know that we can easily define that. And the same with when Ashan was saying that with one of the cases, especially, well, both the cases he presented, but maybe more the first, that it was very evident very quickly that they didn't have autism. And so just as with, you know, sort of what is it that makes that so evident that kids with autism have it, I think the question is the same in the opposite direction. What is it that we see that makes it so obvious that people don't have autism? And I don't think we can define that, unfortunately. And however, what we have seen is that across time, so different epidemiological studies will sometimes use different criteria. And we can see that here. So this was published in, I think, around 2000, but in this one study, I think in England, they looked at sort of prevalence of autism, or sorry, the incidence, so new cases in any year, based upon different criteria. And so using Kanner's original description, it was about 5.6 per 10,000. And my understanding is that that number has never, ever really changed. That autism, as originally sort of defined by Leo Kanner, the first person to describe it, has always been around 6 or 7 per 10,000. And regardless of what other DSM criteria have changed, if we look at that very narrowly defined, very recognizable group, that incidence or prevalence probably hasn't changed at all. All right. So one possible explanation is for the increasing prevalence is that we're actually, as I said, talking about apples and oranges. We're talking about different conditions entirely. And so maybe there isn't an increasing prevalence of true autism, whatever that really means. Second possible explanation is earlier age of diagnosis. So if we think about epidemiological studies, where often they'll take people of a certain age and in any defined geographic area, sort of try and include everybody and get information or assess them for autism. But if they, in the past, let's say if the average age of diagnosis was 7 or 8, that means that there would be some people who would be missed when they were 4 or 5. But if the age of diagnosis has shifted with more emphasis on early intervention, then if we're seeing people now and the average age is 4 or 5 for diagnosis, then obviously that's going to be more people who are identified as having autism at that age who might not have in the past. And so that's what this study from, I think it's Judith Crone in California showed. And it's a bit busy, but each one of these lines represents a different birth year and sort of the average age of diagnosis. And we can see that as time has gone on, so this solid black line is the most recent cohort in our study. As time has gone on, though, the age, what would appear to be the average age, has shifted further and further to the left. And so that means some of these people who in the past might have been considered to not have autism are now recognized as having it. And so that's going to change numbers in any epidemiological study as well. And, you know, there's been some really interesting work in the last few years. There, Laurent Mautron, who's at the University of Montreal, had a study a couple of years ago published in JAMA Psychiatry. This isn't it, but what he showed actually is if you looking at the difference in severity between, or in symptomatology between people with autism and people without, what they found was that over time, that difference has gotten smaller and smaller and smaller. So in the past, the difference in autism symptoms between people with autism and people without was quite large. That's gotten smaller and smaller over time, which suggests that we are diagnosing it differently or something has changed. And what this study suggested was it was age of diagnosis, but also a shift in criteria, but mostly it's age of diagnosis that led to the increasing prevalence of autism, at least in Denmark, where they have I think in Scandinavian countries have better registries than we do for sure. So that is sort of two possible explanations. And this list is not by any means meant to be exhausting, or well, maybe it is exhausting, but it's not meant to be exhaustive. But it's the third one, possible explanation is what's called diagnostic substitution. So diagnostic substitution occurs where one diagnosis is given or substituted for another, and that will change the prevalence of both of those conditions. And so what this is from somebody's blog, actually, but they had taken data from the UK, I believe, on the prevalence of ASD and intellectual disabilities, and then combined. And when they say unduplicated, so this would be people with autism or an intellectual disability, but not both, because people would only be counted once. What you can see is that as time has gone on, the rate of autism has increased, but the rate of intellectual disability actually decreased, which is really difficult to explain and doesn't make a heck of a lot of sense, really. And so the proposal is that what has changed is that people who in the past might have been diagnosed with intellectual disability are now being diagnosed with autism instead. And Judy Crone from California again had another study showing a similar thing with people's birth years and how the rate of what's called mental retardation in this study, because it's older, but intellectual disability has declined at a similar rate, I guess the reciprocal or the inverse, as the rate of autism has increased in the population. So it's possible that one of the reasons for the changing prevalence is that just more people who in the past would have been diagnosed with intellectual disability are now receiving a diagnosis of autism instead. The perhaps more controversial, but actually not controversial explanation for this would be for the increasing rate of autism would be some kind of biological factor. And the one that we've heard the most about and frankly still hear about, it would be around vaccinations. And I think a lot of the questions about vaccines started because people were asking, you know, where were what happened to all the people with autism from 60, 70 years ago? Where were they? Why don't we see them? And the conclusion these people came up with, which is incorrect, I think, is that obviously they didn't use vaccines in the same rate in the past, and therefore that we didn't see autism because there weren't vaccines. And I suppose that is a logical fallacy. And there's been a large number of studies done sort of showing that this is not correct. But it's led to these sort of hysterical, almost magazine covers and people talking about things. And it's still surprises me how often I get questions from parents about vaccines and autism and the relationship between them. So Eric von Bond, who's at the University of Oregon, I think now, but has done a lot of research in this area, published a study, I don't know, 10 or 15 years ago, where he took a number of epidemiological studies which looked at autism and vaccines. And what they found actually was that people who had not received their vaccines, people who had received their vaccines, so the MMR vaccine, you can see in this study, they're all on the left side of the graph, which means that they had a slightly lower risk of developing autism than people who hadn't received their vaccines in these cohorts. It's not statistically significantly different from zero, but nonetheless, it certainly isn't increased at all, which suggests there's no impact. Eric has done a lot of really nice research in this area, and he's said, and I think he's absolutely correct, that there's several reasons that this persists. One of them, and perhaps most important, is that emotion trumps science 100% of the time. That if people believe that their children have autism because of vaccines, and they talk about that, that's going to have a potentially significant impact on other people. The other thing Eric pointed out is that we really, in general, have no idea how effective most of our vaccinations are because we don't see the diseases that they are preventing. That, you know, we don't see polio anymore. We don't see, well, we haven't seen measles and things like that. And so we really have no idea how effective these vaccines are. Unfortunately, though, that is changing. So this is from the CDC. It just shows between 2001 and 2019, the sort of trend towards increasing rates of measles in the United States. And there have been several large outbreaks, and 2 or 3 years ago, I forget exactly when, around the world, there were a number of outbreaks, and it probably has something to do with the lack of herd immunity because of less and less people receiving vaccines. And I think in the Western world, we often forget how significant measles is as a disease. So this is from 2007, but you can see that based upon people receiving their vaccine, so the red line is the number of people receiving at least one dose, and the second one I think is people receiving more. But and the percentage obviously is increasing, but at the same time, the rate of deaths due to measles has decreased pretty significantly. But even still, in 2005, the rate of death from measles around the world was thought to be about 500,000 people, which is a staggering number. And it is very worrying that people are choosing not to have their children vaccinated. So I think that we can exclude, well, personally, I would say we can exclude an epidemic because of vaccines and things like that as a cause of the increasing rate of autism. Final one that really nobody wants to talk publicly about, but personally I think has a significant impact is service availability. So there was a really interesting study a few years ago out of Australia, and I think we have to be very skeptical or at least very suspicious, I suppose, about any study that asks people how often they lie, because who knows then whether people are telling the truth about that. But what they found was that it involved child psychiatrists, developmental pediatricians, and then general pediatricians. They were basically asked several questions. One is, have you ever given a diagnosis of autism that may have been incorrect in order to get services for children? And we see out of again a relatively small study, but about 60% of pediatricians, 37%, developmental pediatricians, and 37% of general pediatricians had done that in the past to get services. And same with in order to get services in schools. And in fact, we can see that over 50% of each of these groups suggested that they had made a diagnosis of autism in order to get people extra services in school. And there's probably no way to actually quantify, well, outside of the study, what the numbers are, but it hasn't happened recently. But in the past, in people coming for assessments, we would often hear parents say, the principal of the school said that you need to get a diagnosis of autism in order to get services. And even recently, we saw a boy for an assessment regarding autism, and he doesn't have autism, but has significant behavior problems and a pretty significant intellectual disability. And when we talked to them about the fact that the boy doesn't have autism, she burst into tears. And one of the things she said, and I felt terrible for her, she's absolutely correct, is that a diagnosis of intellectual disability is not going to get anybody near the amount of services that a diagnosis of autism will, especially at a younger age. And I think we've sort of set up this bizarre inequity almost that people with a diagnosis of autism are going to get more services. And that's actually what we've also seen across the last few years in Ontario. So this is a graph from the Financial Accountability Office of the Government of Ontario. I have no idea how I even came across this booklet a few years ago or publication that they put out, but it was really interesting to look at how the cost of autism services in Ontario has changed over the last 20 years. Or 15. So in 2004, it was estimated to be about $67 million, whereas in 2019-20, it was $608 million. So it increased by tenfold. And in fact, not only that, but the amount of expenditures has increased. The increase in expenditures has actually increased exponentially, going from 10% annually increase to 68% in the last few years. And logically, one would say, okay, so there's more and more money being put into the system. The waiting list must be getting shorter and shorter. And in fact, that is completely incorrect. That the waiting lists have only gotten longer and longer, which is really difficult to explain. If there's more money being put in the system for services and treatment, why is the waiting list getting longer and longer and longer? Unless more and more people are getting that diagnosis, not always necessarily for services, but I think that certainly accounts for it. Or at least some of the increase. So why don't, Verinder, if it's okay, what I want to do for a few moments is just stop and see if there are questions people have or comments about sort of these thoughts about possible explanations for the increased diagnosis. So one question that was asked was, can the reason for increased prevalence over time be due to movement of severity levels?
Yeah, go ahead. Ben Joseph has asked that question.
Yeah, sorry, Vita. So it increases severity level. Now, I'm not sure, Ben, what you mean by 0.5 over 1 to 1 or 2, especially when there are comorbidities. But I think certainly what's been suggested is that the criteria, if we look at them the way I presented them, they've obviously gotten broader and broader, and I think included more and more people who are less severely affected. But I'm not sure, Ben, if you want to type in or say out loud when you say about the movement of severity levels, I'm not sure what that means.
Do you want to proceed with Dr. Curry's question?
Yeah, so Dr. Curry asked a question, some of the increase may also be related to increased surveillance. And I think there's no question about that. It's an excellent point. That I think in the past, pediatricians, from what I understand, were told that that they were missing lots of kids with autism, and they had to be more and more aware and have sort of a higher index of suspicion. And so I wonder if the pendulum has almost gone from one extreme to the other. So I think absolutely increased surveillance makes a huge is part of it as well.
Yeah, and then Leila Schnell.
Although if I
Schnelke-
can, Brenda, I just want to say,
Sorry, go ahead. Yeah.
you know, the way though that the CDC studies are done, they go through, so they don't actually see kids and do assessments because it'd be really unwieldy. But I think they go through records, school records, clinic records, and things like that for anybody who, through hundreds of thousands of kids. And so I'm not, I mean, it may be due to surveillance, but in that case, it may not. But I think certainly there's no doubt there is increased surveillance. And I think at some level, it must have some impact on the prevalence rate. So,
All right, Ben is able to ask you the, or give you the further expand on what his question was about. So Ben, please go ahead. You'll need to unmute yourself, Ben.
Oh, so sorry. It's really about, can the severity level move from say 1 to 2 over a few years, depending on comorbid conditions, and is that the reason for the increased prevalence?
so when you say severity level, you mean like according to DSM severity levels?
Yes.
It could. I mean, that's a really interesting question. I don't know if anybody's ever looked at that about whether severity levels for an individual change over time. And I would suspect they would, depending upon interventions and all sorts of other things. But I don't know how within one person, how a changing severity level is going to change it. But if anything, I said that it would seem that more and more less severely affected people are being diagnosed with autism. I think the one issue that comes up, and we're going to talk about this when you talk about the comorbidities, I think that's what makes it really, really difficult sometimes is distinguishing things in child psychiatry and separating them from each other. But the DSM makes it seem as though everything is clearly and easily distinguished from everything else. And as they say, that's a nice piece of fiction, that's not the reality. And so it is, I think that, and things often appear to be very similar to each other.
Thank you, Dr. Nicolson. We do have a question from Leila Schenkel. Any other biological causes are discussed for the increase, she talks about metabolic and genetic causes.
So not that I'm aware of, although certainly there have been questions about pollution and exposure to environmental toxins. At one point in time in the late 90s, it was at Brick Township in New Jersey. They thought, oh my God, there's this dramatic increase in the rate of autism. And it was thought to be due to industrial pollution in that area. It turns out that the prevalence was not any different than anywhere else. It was just noticed more. But I'm not sure of any genetic or metabolic causes that would relate to the increase. But certainly, I think the pollution certainly has been one thing that's been looked at, and there's been a number of studies looking at it.
And I'll invite Dr. Hansel to ask a question. Dr. Hansel, Kate's going to unmute your button. Thank you.
Hi, Dr. Nicolson.
Hello, Dr. Hensel.
I was just wondering if you would comment on, the service availability for children with autism. And I know that there's this disparity compared to children that have intellectual disability. And, why you think that is. And, my thought goes to the capability for lobbying efforts of parents of kids that have autism spectrum disorder versus kids that have intellectual disabilities.
I think a lot of it is lobbying for sure. I think what we've seen in the last 20 years, 25 years, is that parents of children with autism have been great at getting organized and lobbying the government and getting the ear of the government. I think, and I was actually asking this question to Michelle Palmer a few years ago. So she's the director of Community Living London, about, given that the budget for Community Living London really hasn't changed in the last 20 years and is obviously not enough to support all the services they offer. Why is it that parents of people involved with community living aren't more vocal and active? As you said, in her view, and I think she's probably right, is that people are just too tired, right? As kids get older and older, parents, I think, just get tired of the fight constantly in trying to access things. Whereas parents, since autism generally affects younger children, I think that, parents are younger, they have more energy, and more optimism, I suppose, perhaps.
Thank you. We have a question from Dr. Rajakumar. Difference between autism and ASD in these epidemiological studies?
Hey, Raj, that's a really interesting question because sometimes they will, so not only will they use different criteria for autism in epidemiological studies, but also use different levels of severity. And I think that although in the DSM-5, autism is autism spectrum disorder, previously I think that autism spectrum disorder, that term was sort of used more for a more broader definition than autism itself, so it's perhaps less severe. I think almost certainly what would be seen is in epidemiological studies is that autism spectrum disorder would be more prevalent than autism, at least in those past studies. Now, given that they're the same thing, or we use the term interchangeably, I would assume that it's the same number now, but I don't know that for a fact.
Thank you. A question from one of our participants. Curious about your thoughts about social media playing a role in increase in diagnosis of less severe cases. For example, adolescents who come to appointments requesting a diagnosis of autism.
Well, let me first of all pretend that I'm a good psychiatrist, because it's an interesting question. So if you feel comfortable unmuting yourself, I would actually be interested in what your thoughts are on it. Because it's Joan Gardner from CPRI and I were talking about this recently, was that in the last year in particular, the number of assessments we've had that were driven by an adolescent who had talked with peers or read things and was quite convinced that they had autism. We didn't think any of the handful of people did, but it was really interesting because I something I haven't seen before, where the adolescent had actually asked for an assessment or a referral from their pediatrician or family doctor. And I think in a lot of these cases, it absolutely has been either social media or peers. So with people, they're having a peer who has a diagnosis of autism, so they say, oh, I'm just like them, or they do some scale on the internet and it says they have a high likelihood of having autism. And it's, that's why I think it's a really interesting cohort thing, because one generation ago, nobody would have wanted to self-identify as having autism. I think it was seen as a very, very disabling condition with a very poor outcome. And now, what we see, it's almost the opposite, that people, I don't want to say seek out the diagnosis, but certainly we know there are people who are self-diagnosed with autism. I have a patient, one of whom's parents has diagnosed himself with autism, and in fact said that they didn't need to see a doctor because they knew they had autism. Now, I don't know what impact that's going to have on prevalence, because those people probably wouldn't be included in any epidemiological study, but it's a really interesting phenomenon, I think.
Thank you, Dr. Nicolson. We'll take a question from Dr. Julia Mastrangelo, who has requested.
Hi there.
Ask a question. Yeah, go ahead.
My sort of, I guess, more of a comment about the social media thing, that I think, I know Dr. Nicolson and I have had many chats about autism. And so I think, sort of where I stand on the diagnosis, and that I agree with you that I think we need to try to be careful about how we diagnose this and have specific parameters so that we can have research and treatment that makes sense and all that stuff. But I think that the social media part that's driving this current adolescent generation to seek out this diagnosis, I think it comes from a place that we can all really understand and appreciate, which is these are a bunch of teenagers who are living through a time that is very confusing, very frightening, even for the adults in their life, let alone an adolescent trying to figure out who they are and how they fit into this world that now has to deal with the pandemic and all these things. And they're just looking for answers because they're suffering and they're struggling and they're trying to figure it out. And then they go online and they find people who get them. And they find people who validate what they're going through, and they feel for the first time seen and heard. And they want to belong to this community because it makes sense to them. And so I wonder if maybe some of our efforts to try to keep our diagnostic validity need to keep in mind that these are people and teens and parents too, who are suffering, who need to have some kind of understanding for what they're going through. And I almost wonder if we need to have like a label we need to maybe come up with diagnostic criteria for whatever phenomenon this group is experiencing. Do you know what I mean? I don't know what that label would be. I don't think it's autism spectrum disorder, but I do think it's a real thing.
It's unspecified mental disorder due to an unspecified environmental condition. But I think, Julia, your point is well taken. Because interestingly, of the people that we saw in the past year or two, where the adolescent or the teenager had driven the assessment and had gone and spoken to the family doctor, pediatrician himself, I believe that all of them identified as transgender. And I don't know what to make of that entirely. I mean, I have some thoughts, but it certainly is an interesting thing about, people looking for belonging at times, I wonder. Before we move on, so Dr. Bertoldi, if you want to unmute yourself, you had a comment you want to make on the social media comment.
Dr. Bertoldi also has 2 questions on the Q&A. So while she's getting ready, perhaps we can read out those questions, Dr. Nicolson. The
Sure.
first question is there any data on WHO diagnosis early versus late? For example, level of ASD, type of childcare, socioeconomic status, why they present for diagnosis? So that's the first question. And then the second question is, can or how parents, childcare centers respond to the challenges that mild ASD presents, affecting when kids are presenting for diagnosis, especially since schools have to take kids no matter what. And perhaps by now, Dr. Bertoldi has unmuted.
Can you hear me?
Go ahead. Yeah,
Okay.
Go ahead.
Sorry, I wanted to say about the social media part. So I have a child who watches way too much YouTube. We'll just say I'm a bad pediatrician and a bad mom. Get that out of the way. But I had noticed, so like you said, Dr. Nicolson, you know it when you hear it, right? Or you know it when you see it. Anyway, my then 7-year-old, because it was last summer, had found these YouTubers that he liked. And I thought it was a relatively harmless couple of YouTubers who seemed to be friends, and they produced these YouTube videos. But I had kind of listened to what they were, and I thought, oh, cute. A couple of Aspie YouTubers have channels together, and isn't that fun? But I had noticed by the end of the summer that my child had developed some odd language patterns. And I'm like, what is going on with my kid? He's starting to speak like a lot. Sorry, I still do use the term Asperger's because I have some patients who got very upset when their diagnosis was taken away. But I'm thinking, my kid is talking like he's developing Asperger's. What is going on? And then I recognized, wait a minute, he's talking like the YouTubers he's watching. And once he went back to school, it got better. But that was quite startling for me. And I started to think, what about the kids who are watching even more of this all the time? Especially
over the last few years, with COVID, kids being at home all day, every day.
Yeah.
And I think it's going to be really interesting and concerning to see how that plays out. Because just the amount of screen time, ignoring what you said for a moment, but just the amount of screen time that kids have had, I think for parents to now get their kids out of that pattern is going to be incredibly difficult. And certainly you sort of wonder about about how people are being influenced and what they're seeing in the media. And I think that's part of the difficulty, is that the diagnosis of autism has changed so much over the years that I don't know if any of us really have a good sense anymore of what it means.
Yeah.
And so that's where I think that in schools and things like that, when people are wondering what I have this idea for a study I'd like to do that I never will, but where, when we get referrals for kids with autism, to actually call the person and ask them, what are the criteria for autism? Is there any sense of that, or is it just this idea there's some general social dysfunction, or what is it? But I mean, it's interesting. We were commenting about the speech patterns, and I haven't actually heard anybody say that before, but I've not asked, and that's a really interesting observation on your part.
Yeah, I mean, and again, when you said, I know it when I see it, right? Because I see a lot of kids with level 1 ASD. I'm not diagnosing them, they're being diagnosed and I follow them. But they do have a kind of a very common kind of speech pattern, right? Like, it's just their word choice and their very concrete use of language and social pragmatics and stuff like that. It's just kind of, it is what it is, right? But I was also curious, So I'm old. When I was doing pediatrics, we were told that ASD or autism was not genetic. Okay, so I'm very old because that was a long time ago.
Older, actually.
Okay, there you go. I'm older. Thank you. So what is there anything, what do we know about the kids who are presenting earlier versus later for diagnosis? Is there any, like, do we have any data on that? Like what brings them to attention earlier or later?
So, you know what, I mean, that's an interesting question. And there were a few papers recently, and off the top of my head, I can't recall what they showed. And I mean, certainly, I think I would imagine more severely affected kids are going to be seen at a younger age. But I think, and this is where the United States and their insurance system skews things a lot, because people without insurance aren't necessarily going to be seen as quickly, or they're not going to have the same access. I think there are racial differences in the prevalence of autism in the United States, fairly significant actually, that don't make any sense other than if we think about it from an insurance perspective. Even across different sites in the CDC studies, and sometimes there's a fairly wide discrepancy in different areas of the United States that, again, are hard to explain biologically. And it probably has more to do with access to services and insurance, unfortunately.
Right. Some of the kids that I've seen who did present later, I mean, one of them, it's funny, their mother is an EA working with kids with autism. And she just automatically did the stuff at home that she would have done at work, which her child responded to. We also have an amazing childcare center here where they're they call them universal supports. They're not universal because nobody else does them, but they just automatically put into place stuff that you would put into place for a kid on the spectrum. And the spectrum kids that I send there do beautifully. But also I've had other kids who've gone there preschool wise and end up in school and crash and burn because they don't get the same kind of supports that had been in place in this preschool program. And it turns out they are on the spectrum when we send them off, but it wasn't really recognized because they did so well in preschool, and the preschool trained the parents who started doing it at home, and they did very well until they got to school and all those supports weren't there because they're not universal in school.
Well, you know,
does that make a difference?
I would assume, and that's where, you know, I could say at a global, universal, theoretical public health perspective that we shouldn't be making diagnoses for the purpose of getting services.
No.
But at an individual level, it's tougher, isn't it? Like with the kid I was talking about, whose mother was, you know, was heartbroken that we didn't diagnose her son with autism, which again is in a way kind of crazy, right? But I think her point was very well understood, that, you know, that he just wouldn't get the same level of services. And I don't know how we change that. I mean, I think that's a really good question. What I want to do though, Margaret, if it's okay, is I just want to move on and we'll come back to questions after.
All right. Thank you, Dr. Bertoldi and Dr. Nicolson. Dr. Curry has a question. Can you also clarify?
I got more to go still. So can we leave?
Okay, perfect. No problem. Yeah.
Okay,
there are lots of questions. We'll just park them for now. Thank you. Go ahead. Yeah.
Okay. So, you know what, ultimately at least from a medication or pharmaceutical perspective, you know, maybe our diagnoses don't matter because we're going to treat aggressive behavior the same way. We're going to treat hyperactivity the same way. So ultimately we could say, you know, who really cares whether we get the diagnosis right or wrong? And I think it's important for a lot of reasons. So first of all, clearly prognosis, parental expectations are affected by this. That in general, I would think we would say that people with a diagnosis of ADHD or social anxiety are going to have a better outcome on average than people with a diagnosis of autism. And I think for parents, it's important to get it right. And for family planning. I think for educational and life planning, it's also important. So one of the things that I learned from Dr. St. Pierre, who I believe is a tenant, is things that we, you know, in making a diagnosis, we don't even consider. So if parents are if a child has significant autism and intellectual disability, if they're putting money into a registered education savings plan when they shouldn't be, when it might be more appropriate to put it into a registered disability savings plan or things like that, I think are really important, but also planning for the educational system. The Thames Valley School Board has several classes for children with autism, and having seen many of those kids, I'm a bit curious about the actual makeup of the diagnoses in those classes. And so, services, and unfortunately, this becomes with the tail is sort of wagging the dog a bit, because the more diagnosis there is, the more diagnoses are made of autism, the more demand there is for services. But then with more services becoming available, I think there's more demand for the diagnosis. And so it just goes around and around and around. And I think, with service delivery and allotment of resources, I think we saw from the Financial Accountability Office of the Government of Ontario that waiting lists have only gone up in the last 20 years, despite a huge increase in funding. And I suspect that what happens is that, yes, people with a diagnosis of autism are going to get more services, but they're not necessarily appropriate services if they don't actually have autism. So, for example, with intensive behavioral intervention or early intensive behavioral intervention, there's not any evidence that children with significant intellectual disabilities who do not have autism will benefit from that kind of therapy. And so, yes, they would get it, but it's not necessarily going to be helpful and may not be the best course for them. And so what that means then is sometimes children are on the wrong waiting list for services, and they're also occupying spaces on the wrong waiting list, which creates problems for them in terms of services and treatment as well. So what makes it difficult? And I think there's a number of factors. So first of all, we have I think one of the problems we have in psychiatry in general is the whole question of validity, right? So how do we know that a diagnosis is correct? We don't have a gold standard against which to compare things. It's not like pneumonia where we can do an x-ray and have a sort of definitive answer. And at some level, everything we do has some subjectivity to it. And so we have standardized diagnostic instruments, the Autism Diagnostic Interview and the Autism Diagnostic Observation Schedule, and the reliability among trained people is fairly good, but it's certainly not perfect. And there are disagreements. And what studies have shown is that in children who are diagnosed sort of rigorously with autism in sort of well-established university centers using sort of a number of different assessment tools, that the stability is fairly high, but it's not again 100%. That some people their diagnosis does change over time. And so this is some work from Kathleen Lord also. And what they found was, so they did these assessments on 2-year-old children, and what they looked at was, so they're sort of their best estimate diagnosis. So the best estimate was sort of taking everything together, all the information, and that's in these rows here. But people who were at the age of 2 diagnosed with autism based on clinical assessment without the ADI and ADOS, again, there's fairly significant, fairly stable, but at the same time, so just under 10% of the kids, their diagnosis changed over the course of 7 years with the exact same assessment being done. And using the best estimate, it's sort of looking at all the information, numbers still change somewhat, which is difficult to explain. And then I've thought about this over the years, how do we explain that when we see a child at 2 or 3 and they look very, very classically autistic, and yet you see them 6 or 7 years later and they don't seem to have autism anymore? What's changed? And I think and we don't really know. That Deborah Fine at the University of Connecticut has done a fair amount of research in this. And I guess in my own mind, I think, there are 3 possibilities. One is that through early intervention, people improve to the point that they no longer have autism. Or secondly, they quote unquote grew out of it. I think the third possibility is they never actually had autism in the first place. They had symptoms that looked very much like they had autism, but it wasn't actually autism. And as they got older, that distinction became more apparent. And actually, I was just, so as I was thinking about what Julia Mastrangelo had said about, that certainly when we see people coming for assessments, it's not as though they don't have problems and significant issues. And I don't want to give that impression. It's more that I don't think their issues are necessarily always in the realm of autism. So, I think the other problem, and this is, I think, related to the DSM, is that there are all kinds of cognitive distortions that we make. There was a book written by Jerome Groopman, who wrote for the New Yorker and the New York Review of Books, and I don't mean to sound pretentious by saying those two. And he actually wrote a book on how doctors and how professionals think, and talked a lot about the cognitive errors that we see. And I think certainly one of them is the idea of a confirmation bias, that generally within a few minutes of seeing a kid for an assessment, we have a pretty good idea, or an adult actually, we have a pretty good idea of what we think the problem is. So, but unfortunately, we then tend to look for information that confirms that, and we don't tend to spend a lot of spend a lot of time looking for information that disconfirms it. And so we sort of go down a path. And I think that that's in a way what the DSM does, right? So we see a child and their social behavior and communication look very much like they have autism. I think then people almost start sometimes trying to fit them into the diagnosis or force them into it. They start looking for, okay, so what are we going to call the repetitive behavior? What are we going to call a ritualistic behavior, instead of looking at the big picture? And I think that the DSM unfortunately sort of encourages that kind of thinking. So, as I mentioned earlier, that there is a huge overlap in the symptoms of various psychiatric illnesses, particularly in childhood, where we don't have that long-term pattern. It's not like an adult where we can look back and say, okay, here's what's changed over time. And Lawrence Jerome had a question in the Q&A that we didn't get to, unfortunately, about the relationship between ADHD and autism. And so I'm going to come back to that in a second. But so there are a number of disorders that have quote unquote autism-like features. And I think that's perhaps because essentially every significant psychiatric problem in childhood, I think, is associated with social difficulties. It sort of cuts across everything. And I think that creates a lot of confusion. So, children with ADHD, particularly with greater severity, often have social and communication difficulties. And there is a long literature going back many, many years about the social difficulties that kids with ADHD have, and that, they tend to be impulsive. They say things that cause difficulties. And in fact, there was a study out of the University of Michigan about 10 years ago where they looked at a group of children with fetal alcohol syndrome who clearly did not have autism. And then they had another group of children without fetal alcohol syndrome who had a diagnosis of autism. And they compared them on their histories, so using the Autism Diagnostic interview, and they found it was, on paper, difficult to distinguish between them, even though in reality they were very, very different. The only things that really distinguished them were the nature of their social initiations and the nature of their social interactions. And what I think we find in CPRI and here at LHSC is that what becomes more and more difficult is when we talk about a comorbidity. So people with not just ADHD, but also people who have significant language problems and ADHD, or people who have significant cognitive impairments and ADHD, and how that also can affect social difficulties. So it's one study from, I think, a group at Johns Hopkins. And this was based on, these are all children with a diagnosis of ADHD, none of whom had autism. And they gave the parents of all these children the social reciprocity scale and asked them to fill it out. And they were actually looking at kids with ADHD who had motor problems or didn't. So the lighter gray is children with boys with ADHD who didn't have motor problems. And the darker black or gray or whatever we want to say is boys with ADHD who had significant motor problems as well. And what you can see is that among the latter group of people with motor problems, a significant percentage, actually, 60% on the SRS met the threshold for autism. And so even though none of these kids had autism and had never been diagnosed with it. So on paper, there's a huge overlap. We see the same thing with anxiety disorders. I think particularly perhaps social phobia, where people with social anxiety often are not going to make eye contact. They aren't going to initiate interactions with people they don't know. It's going to be very difficult for them. And I would say would go with selective mutism. And again, we can see that a significant number of people with, this is from Danny Pine at the NIH, and a significant number of people with anxiety problems in childhood met the criteria for autism based on the social reciprocity scale. Far fewer on the social communication questionnaire, which I guess is good. But nonetheless, it clearly is a confound. So one of the most common things that we see at CPRI in kids that and here at LHSC in kids that were sent for an assessment but don't have autism, or we don't think have autism, is with language disorders. And I think that what Joan Gardner and I have been talking about for many years is that there's a lot of information out there for parents of kids with ADHD or parents of kids with intellectual disabilities or parents of kids with autism or anxiety disorders there's almost nothing available for teachers and parents regarding language disorders and the severity and the profound impact they can have on people's lives. And what studies have shown is that in kids with severe language problems that don't resolve, they often have very poor outcomes as adults with a lot of social difficulties and employment difficulties, which makes sense that both of those things, language is necessary for essentially everything we do in life. And if your language is disordered, it's going to make all these things much more difficult. And it's going to have an impact on social interactions and things. Patricia Howland in England. So this is from a group of adults actually who had been seen in childhood and had very severe language disorders that persisted. And what they found was that when it came to play and leisure skills and coping skills, that they weren't that different actually. In terms of sort of having significant impairment, people with autism had more social difficulties and overall, but nonetheless, there was a lot of overlap as well in terms of impairments in adaptive functioning. The other one that we see a lot, and I think I'd say what happens mostly when we see kids at CPRI is we have people with not just one of these problems, but multiple things. But so we know that the rate of intellectual disability has increased in people with autism. We used to say it was 2/3 to 3/4 of people with autism. Most recent studies suggest 35%, but regardless, it's still dramatically higher than the 1% in the general population. And what studies have consistently shown over many years is that the lower you go in cognitive ability, the lower you go in IQ, and the more sort of severe the developmental impairments, the harder it is to distinguish autism from intellectual disability. And so when the DSM, each iteration is being developed, they do field studies to look at how it changes to the diagnosis will impact things. And what they found was that looking at the diagnosis of autism, I think this was with DSM-5, they found that when they did the field studies, the rate of false negatives was low, but the rate of false positives was high, particularly, and this was in people with intellectual disabilities, but the lower that they went in IQ, the more significant the higher the rate of false positive diagnoses of autism were. And they said 60% for those with IQs less than 30. I think because in those people with that level of impairment, they're so severely affected in all their realms, it's very, very difficult to know what's what. And then that's where I think we have to look at their developmental ability, right? Not their chronological ability. So they are going to have more difficulty interacting at age appropriate level with peers, and thus have difficulty developing appropriate peer relationships. And their language and social communication are also going to be significantly affected. But that's, I think, one of the things that the DSM-5 has done that is incredibly important is in their criteria for autism, they've added one thing that wasn't there previously, and basically just says that if people have an intellectual disability or global developmental delay, in order to also get a diagnosis of autism, there has to be a significant discrepancy between their social communication ability and their general developmental level. So their social communication should be markedly below their general developmental level. And ultimately, conceptually, that's what I think autism is when you have a sort of a level of intelligence and a person's social ability or overall development is markedly below what you'd predict based upon their level of intelligence. The final sort of confound, and this is something that I've wondered about over the years and really can't find any research done on, is, what about personality disorders, particularly schizoid personality disorder? And I have some doubts personally about whether schizoid personality is actually a disorder, but regardless, we know that schizoid personality is characterized by a lack of friends, emotional sort of flattening, preference for solitary activities, limited interests and stuff like that, which certainly sounds at least very similar to the A criteria for autism. But I can find almost nothing about the early childhood of people with later diagnosed with schizoid personality disorder. And so are some of the kids who are being diagnosed or being seen for a question of autism, are they going to grow up to be schizoid adults? And I don't know, and there's no literature on it, but certainly something I've wondered about, because there is, on paper anyway, there's that significant overlap. So let me wrap up and then we can have a discussion. So the incidence and the prevalence of autism have increased dramatically over the last 30 years, probably due to many factors. Largely, I think, the diagnostic criteria, and the increase is largest at the milder end of the spectrum. So as I said earlier, people who are more severely affected, sort of classically autistic children and adolescents, the prevalence of that group has probably never changed. But But with the increased rate of diagnosis, there's been an increased demand for services. And what makes distinguishing things is this huge overlap in centers, particularly in children, where we don't have a lifetime to look back upon and sort of see what develops into what. I think one way to distinguish between autism and other things is first of all, spending time with the kid, as Ashan said, and also looking at the quality and the quantity of their social behavior, but also their restricted and repetitive patterns of behavior, because I think that's what ultimately distinguishes autism from kids with ADHD who have severe social difficulties, or people with OCD, with social anxiety or things like that. And what I'm always reminded of when I started at CPRI in 2000, it might have been 2001, came across a chart which Mervyn Fox, who was the pediatrician in chief, or chief pediatrician at Thames Valley Children's Center, he had written on a chart of a young man, a boy, and I'd been asked to see him later on. And what he said has always stuck with me, though, that not every oddity of personality and temperament can be explained by a psychiatric diagnosis. Some people are just different. And I think that is something that has been really forgotten in the last couple of decades, unfortunately. So these, again, I think this is more my own thoughts about, how we account for things, but it's sort of how I explain sort of how we've got to this point of the rapid increase in diagnosis and the changes in patterns. And so I will stop there. Actually, no, I'm going to repeat myself for some reason, but I will stop there and be happy to take questions and have a discussion.
All right, thank you, Dr. Nicolson. We'll go back to the questions that are posted. Dr. Curry says, can you also identify the school board thing that was happening before COVID? I think you said earlier that they do not tend to operationalize psych MD recommendations or psychiatrist.
So I guess, so first of all, don't take too much of what I say seriously, that I tend to ramble on about things. So I always say 50% of what I say is correct. I just don't know what 50%, unfortunately. But I mean, my experience has been that writing letters for schools, other than going on somebody's OSR files, I don't know how much difference it actually makes. And I think that school boards have just like hospitals, just like CPRI, have had a really difficult time hiring psychologists over the last few years. And I think I agree, it was a problem before COVID that people were told there's a 2-year waiting list and schools are only allowed 1 or 2 assessments every year. But I think the fact that the psychologists couldn't get into schools for a period of time really backed things up also.
Thank you. Dr. Warren has a question. Any thoughts about the rising age of parents having their first child over the last few decades and possible link with diagnosis?
So there have been several studies showing that older age of fathers is associated with a higher risk of autism. But I think that risk is also applies to schizophrenia. And it's because you're, males, we continue to make sperm throughout our life. But as we get older, there's more and more likelihood of mutations and things. And so, yes, there's studies have shown that definitely there's a higher rate of autism among fathers above a certain age. However, the increase is fairly small, that it's statistically significant, but only in population levels. And so I don't think it would account for the increase in autism that we've seen over the last 20 years.
And then Leanne Davidson has, again, with respect to the same area. Yes, I also think about the increased surveillance rate. Parents are with their children so much more than in the past. Just a comment.
Yeah, no, I think that's a great thing. And people, and with the internet, there's so much more information available. And people who are not professionals in the field aren't going to have the same level of knowledge. They can read things, but won't necessarily be able to interpret it or apply it in the same way. And I think that is, and I think that, so yeah, people are watching because I think parents are just more anxious about their kids now than they were in the past also. And I think that's where we've seen this sort of whole industry of Kumon. They have early and other places, I think Oxford Learning Centers, they have, programs for little readers, so you can help your kid at the age of 2 learn to read and things like that. And so I think it's just so much more involvement, as was said.
And another question from one of our attendees: with respect to environmental influences, your thoughts on the impact of decreased social opportunities for toddlers, preschoolers through the pandemic, increasing use of screens starting from infancy, etc.
So, it's an interesting question, and I am really interested, as I said, to see what happens in the next 2 or 3 years. with other people who were in preschool or would have been in kindergarten, especially in sort of the 2019, 2020 school year and 2020, 21, where people were out of school for a long period of time and didn't have the same opportunities for socialization. However, I don't think that should drive an increase in the rate of autism. That we, from studies done in Romania and other places with adoptees from orphanages, where children had all their physical needs met, but not really their social needs. And what was found was that if they, when they were adopted to British homes, they often looked very, very much like they had autism. But children who were adopted before a certain age had significant improvements. So I think it's going to cause social problems, but I don't know so much that it's going to cause an increase in the rate of autism. But I suppose that remains to be seen.
Okay, thank you. We have a question from Dr. Alexandra Nowicki. Can you comment on Asperger's and why this was a separate diagnosis in past and is now no longer? Patients, parents that I see seek this out as a diagnosis.
It's a great question, Alexander. So it was interesting because Asperger's syndrome wasn't included in the DSM until DSM-4, and then when DSM-5 came around, it was gone. So it was a brightly burning star that blew out too quickly or whatever. And so I think that the reason it was removed was that within the so-called autism spectrum, I think are fairly good at distinguishing. Well, I think people who are well trained and have a lot of experience are good at distinguishing autism from not autism. But within the so-called autism spectrum, people were really not good at it. And I think a number of studies suggested that if you look carefully enough, that people diagnosed with Asperger's often had autism. And I think that if we're going to call things by different names, we should have evidence that they are in fact different things. And there really isn't any evidence of that. That people with Asperger's syndrome might have better outcomes, but that's because a diagnosis of Asperger's syndrome excludes an intellectual disability. And so on average, people are going to have better outcomes. Peter Zatmari in Toronto and I have differing opinions about the relationship of Asperger's syndrome to autism. I think Asperger's syndrome, the way it was defined, was autism without intellectual disability, whereas Peter would say that autism is Asperger's syndrome with intellectual disability. So slightly different views of it, but it was taken out because it wasn't diagnosed reliably.
All right. Well, I'll invite Dr. Goldberg. He has his hand raised. Dr. Goldberg, please go ahead and ask your question.
First, am I okay? Can you hear me now?
Loud
Yes,
and
we
clear.
can. Yeah.
I think Dr. Nicolson has done an excellent review of trying to explain the epidemic of autism over the past several years. And it looks as if it's pretty well correlated with the diagnostic criteria. I did a review 60 years ago of the nomenclature in childhood psychosis, going all the way from Benjamin Rush in 1812, talking about insanity in children, up until Kanner, of course, who given us the major criteria, and then leading up to the present time. I agree with Dr. Fox's concept that perhaps we shouldn't be looking at the diagnosis, and perhaps going along with the people who now talk about neurodiversity. And that perhaps child psychiatry, we've been looking in vain, including the genetics of autism are multiple, and nothing specific seems to show up. And so perhaps if we accept the concept of neurodiversity, we should go in the direction of attention deficit disorder as a diagnosis, and then take a look at the symptom complex that we have to deal with and try to assist with whatever symptoms the child is developing. And that perhaps that's all we can do for the time being. But congratulations on understanding why there's been such an epidemic.
So as always, Ben, thank you very much for that comment. And, I'd be interested in hearing tonight about sort of what you've seen in the change in the diagnosis of autism over the years. But, I wonder though, and this is the other reason I think diagnosis, getting it right, matters, because if somebody is incorrectly diagnosed with autism, but if they then participate in research, they are going to, their data is going to be part of group averages, and it's potentially going to skew things. And so, you know, when you say we haven't found anything, is that because we have, first of all, included people who don't have autism in research, and also because it's such a heterogeneous diagnosis now that we're not going to find anything. And so I think one thing that people have been doing unsuccessfully is trying to look for subgroups. Personally, what I think we should do, and it's not going to happen, would be to actually go back to diagnosing autism the way Leo Canada did, right? In a very, very narrow way. So we only include sort of classically autistic kids with a diagnosis of autism, and everybody else we put in sort of a category of, you know, that we're not sure what's going on. There are clearly problems that need to be addressed. And then theoretically, what would happen is 30 years down the road, somebody would go back and take a look at these kids in this undifferentiated category and see, you know, what symptom clusters in childhood lead to what outcomes in adulthood. Because I think that once people have a diagnosis of autism, it tends to stick like glue. And I just wonder how many false findings we have because of that. There was Dorothy Bishop, who's a speech and language pathologist in England. She had a blog a few years ago where she talked about, you know, with big data and stuff and the diagnosis of autism, that autism is now associated with almost everything. So, you know, older mothers, younger mothers, older fathers, younger fathers, obese mothers, mothers who don't weigh enough, people who smoke, people with all these contradictory kinds of things. And I think it's because, in part, we just don't have the phenotype down properly.
All right. Thank you, Dr. Nicolson. Dr. Kamini Vasudev has a question for you.
Yep.
Dr. Vasudev, go ahead.
Thank you. Thanks, Dr. Nicolson, for a wonderful presentation.
Thank you.
As you know, I am an adult psychiatrist, and I was wondering if Dr. Nicolson could give some pearls of wisdom for the patients
Kate,
who...
is Dr. Vasudev there?
Yep, she's talking.
Can you hear me?
Dr. Vasudev, please go ahead and ask your question.
No, she has been, Verinder. I could hear her fine.
So great, if you could hear me.
Yep.
So we often come across, you know, patients who obviously were not diagnosed as a child, and they may have a milder version of autism spectrum disorder, what was historically Asperger's. And they obviously have done their research and gone through all the criteria, and they are coming to endorse, for us to endorse a diagnosis. Unfortunately, in the adult world, there are not many resources available for confirmation. We used to have Dr. Templeman, who I think maybe I overwhelmed with my referrals, and so he stopped seeing the adults for autism spectrum disorder. So are there any resources we can refer these patients to for diagnostic confirmation as well as for support in general?
So in terms of support, I think that the Autism Society of Ontario, so it's a parent support group, I think is as good as anything out there. And in fact, the London chapter is fantastic. They have a lot of activities with a lot of educational things, but they also will do things like they'll rent out movie theaters, but leave the lights on and turn the sound down low. So it's more user-friendly for people. They have a lot of family gatherings and I think it's a fantastic organization. And they also have a social groups for people who are older. You know, in terms of diagnosis stuff, I don't know. And it's you know, if autism is meant to be a disorder of early childhood, I sometimes wonder when people who are adults are diagnosed with autism, how the early developmental history was obtained. That I think that the DSM, they've changed the numbers, but it says still that evidence of the diagnosis should be present early in the developmental period. It doesn't say people have to meet the full criteria, but there has to be evidence of a problem. And if somebody's parents are no longer alive, I don't know how we would get that information. Apart from perhaps school records and things like that, but not everybody's going to have their report cards. I don't know the answer to your question, and it's a huge issue because certainly it's something that I get asked fairly often, and I don't know.
Thank you. No, I mean, these individuals who are adults, they do mention that, but it's all very subjective, that during, you know, early life and early developmental history, they did have difficulty communicating, reciprocal and understanding, and that they couldn't get the jokes or they couldn't get the sarcasm, and they were surprised by people responding the way they were to their statements. So there is subtle history, but it's all very subjective. Unfortunately, we don't have objective evidence from childhood. There are rarely school reports available, other things. So that's why it's become very, very difficult for us, except for just kind of validating that, yes, there are concerns. And I do refer them to the Autism Society or the Autism Ontario website, I think, which is very helpful. Yeah, I don't know for diagnostic clarification if there is any help available for these individuals.
No, and I think comedy, the interesting thing, and I don't mean to question anybody's integrity, but if people are coming to you thinking that they have autism, and then they themselves give the history of early developmental problems, I think there are different motivating factors, perhaps.
Yeah.
And I don't, but I often wonder why, right? So I heard sometime in the last 5 years about somebody who was in their 70s who was diagnosed with autism, and I never really understood why. And I guess maybe that's the wrong way to look at it, but I'm not sure what benefit there would be at that point in somebody's life.
Yeah, but these are patients, Dr. Nicolson, where I actually suspect, because objectively they do present socially quite awkward.
Yep.
And when I've ruled out there is no other, comorbid disorders which would actually fit the criteria, the diagnosis for them, because they're looking for anxiety disorder or treatment of depressive disorder, but actually they might actually have Asperger's. So it's basically a treating dilemma for me. Like, what do I do with these patients?
Well, I mean, when it comes to treatment, I think I strongly believe that we cannot treat any psychiatric illness. We can only treat the symptoms. And I think it would be the same thing, right? We'd be treating symptomatically. But it worries me a bit, though, because I hear people saying what you just said now, that it can't be, it's not this and it's not that. So all that's left is autism. But I think our diagnosis should be based on positive evidence for something, not the lack of evidence for anything else. But it is a huge problem. And I think the other issue in terms of services is that because different ministries are funding things, everything is focused on childhood. And once people hit 18, services just fall apart. And it's a huge problem. It's going to become more and more of a problem, I think, especially with people living longer and longer and stuff like that.
Thank you.
Thank you, Dr. Vasudev and Dr. Nicolson. We have a question posted from Elizabeth Roach Fox. She says, she wondered if you could comment on autism as a diagnostic category comorbid with severe intellectual disability. There seems to be positive quality of life impact with the addition of an ASD diagnosis by virtue of the additional services provided. Apart from extra support, can there be a discussion about diagnostic validity, and how can we define this beyond criteria fulfillment, i.e. linked to utility of ABA, etc.?
So first of all, hi, Elizabeth. I hope you're well and are back at work. Everybody's missed you a lot. And I hope the baby is well. Also, I should say before other people think there's something else going on with you. But, I think that's what I was saying earlier about, I think what the DSM, when they added that statement, that in people with intellectual disabilities, in order to get a diagnosis of autism, there has to be a significant discrepancy between their social communication ability and their developmental ability. And I had many talks with Simon Levine about this over the years, and kids who are really severely and profoundly intellectually disabled, how do we make a diagnosis of autism? And the way I think about it now, more than anything else, is just in people who are very severely intellectually disabled, do we need a second diagnosis in order to explain their difficulties, or does intellectual disability in and of itself account for all of their problems? And it's, but I think your comment though about the positive quality of life with getting that diagnosis, and I think that's what creates the difficulty, right? I mean, our job is to do no harm and to help people, and I think probably the best help I could give each individual would be to diagnose them with autism, because there's going to be a lot more services. But I don't think that's helping our society or I think at a more global level, and I think that's the real problem we face.
Thank you, Dr. Nicolson. The next question is from Dr. Richard. The term neurodivergent is now very trendy on social media among youth. I didn't know this word until I was in my late 20s. So she's just making a comment here.
So I guess,
don't know whether you want to respond to that.
I guess, Julie, when you say it was in your late 20s, that was probably in the last 3 or 4 years then?
Oh, thank you, Rob. That's very kind. But actually, I did. Can you hear me okay? Because I actually wanted to.
We can.
Okay. Yeah. So from what you and Kamini were talking about, so when I actually started as staff at LHSC, one of the things they asked me to do was an adult autism assessment clinic. And I said, sure, okay, because I was already taking on some of your folks into adulthood. And your point is very well taken, that the services, once people leave the high school arena are abysmal, and we see a big drop off of services and a big increase of anxiety and depression for those already diagnosed. But I did start the adult autism diagnostic clinic very briefly, and it was a flaming disaster because the referrals that were sent were wildly inappropriate. And you could kind of see where sometimes people were coming from. I probably did about 20 before I decided it wasn't a great use of time. And the one person that I did diagnose was actually a refugee. And so it made sense that they had not had the opportunity to be diagnosed, and now was being diagnosed as an adult and couldn't be assessed because of the language issue for a long time. And this is a true story. At the time when I actually, like literally the consult where I shut it down and said, I can't spend spending a half day of, public time when there's other people on the wait list is not a good use, was a husband and wife combination. At middle age, the wife had wanted the husband referred, so the family doctor referred. Wife was a nurse, husband was an engineer, and the wife felt that he met criteria because he didn't like talking with her, didn't understand her feelings, and on weekends would want to be in the garage with his tools instead of spending time with her. And so she had fit all of their marital issues into a diagnosis of autism, and I knew at that point that this was not a good use of public health dollars. And so I decided that wasn't the most efficient way, because as you said, it takes 2 to 3 hours. It takes looking at old records. Like it's a very intensive process to kind of figure out if the diagnosis is accurate. But the people who really struggled with not getting the diagnosis were individuals with, I think, a lot of emotion regulation difficulties, history of interpersonal difficulties, people who might be on, have kind of more personality disorder type issues, or a history of trauma. I actually found that there was a high degree of individuals who had a history of trauma, who had legitimate interpersonal difficulties, trouble being in groups, trouble reading the room, but generating from a history of trauma and difficulty trusting and attaching to people. And I've seen that theme come up quite a bit. And so again, I think especially because folks are looking for answers and often going to social media and, trying to find words like neurodivergent or autism to explain their distress, that, we can kind of take different aspects of this elephant of the diagnosis and make it fit to you, right? Depending on which aspect you feel connected to. And so it's been interesting to me how upset people are if I suggest this isn't the diagnosis, and instead it may be related to something like trauma, right? That people become very attached to this possibility that they have a quote unquote true neurodivergent difference. So that's just been interesting.
Well, and I think, Julie, I told you that I once had a mother of a patient send a formal complaint to the college because I said her son didn't have autism, which again, if we think one generation back, I mean, that's insanity, really. It would have been, people would have wanted to hear their kids didn't have autism 30 years ago. But one thing that's always stuck with me also, Julie, that you said once was that in your clinic, that the people that you follow with autism, even so-called higher functioning autism, I think you said they tend to do much more poorly than people with schizophrenia do in the long run. I mean, would you still say that?
Yes, I would actually.
Why do you think that is?
So I've got a couple of thoughts, but in brief, what I will say is that, I think the educational system does an excellent job supporting children and youth with autism. Like we have PDD classrooms, we have excellent resources, but I think unfortunately it creates a bit of a buffer, right? And then when people reach 21 or whatever that cutoff is and emerge from those very supportive environments with very well-meaning teachers and professionals like PDD classrooms, it's a really harsh drop off into the adult world, right? Without a lot of, bridging services, and that's very overwhelming. Whereas I think on the flip side, although individuals with schizophrenia initially have kind of a devastating, first few months while they're trying to cope with this new diagnosis, they've already had some time kind of experiencing the world, as usual and navigating the world and things. And so they're more able to kind of get back on track with that because they have those skills, that we just need to kind of help, coach. Is more about kind of just, recovering from the episode and then using their innate skills, which I don't think that individuals with autism have innately developed, because I think there's a degree of support and the teachers mitigating the fact that they're missing those skills, right? Very well meaning, but I think that we don't realize the extent to which there's a deficit in those skills until they hit the adult world, right? Whereas I think in psychosis, most of those folks will have already developed some degree of those interpersonal and kind of life management skills, and we just need to help it continue along. But for individuals with autism, there's a full-on stop in terms of functioning once those supports and buffers are taken away, and the parents are often left doing everything at that point, regardless of IQ.
So do you think if people, how in comparing adults with autism that you've seen compared with people with schizophrenia who have really predominant negative symptoms? do you think that the group of people with schizophrenia would still have a better outcome?
I guess it would depend on what the measure is. Like I would say for a given person with autism, a given person with schizophrenia who are, say, motivated to be employed or work on or live on their own, that individual with schizophrenia will do better if they're motivated to those tasks, right? I think if there are negative symptoms, they may not be motivated towards those goals. But the last comment I'll make is just as a thought is probably my highest functioning autistic patient. His mother decided, and I'm not saying that this is correct for all people with autism, but his mother decided to pull him out of high school at one point and take him to work with her. And she was an Avon sales lady. And because of his work in Avon sales, he has the best interpersonal skills of any of my autistic clients. And he's actually in the low IQ range. He's mild to kind of moderate intellectual disability, but he worked in a public service area for years. And so has that comfort. Whereas I think other folks are very kind of supported within an environment that doesn't reflect the real world. And I worry that they're not ready once they hit that adulthood piece.
Yep, I agree.
Thank you, Dr. Richard.
I think.
Yeah, go ahead.
I think Sandra had a question.
Yeah, I was going to ask Dr. Fissman to go ahead and ask her question.
Sure. We're running out of time, but Rob, thank you. I wanted to just comment about avoidant personality disorder. So I think the roots of avoidant personality disorder are different. If you like, it's an extension of extreme stranger anxiety. So
are you talking about avoidant personality or schizoid?
Avoidant personality.
Okay. Yep.
I think, isn't that what you mentioned? Avoidant personality?
No, schizoid.
Oh, okay. Well, my comment is about I think schizoid is perhaps more on the schizophreniform spectrum.
Yep.
Sort of odd, unusual people. But I think avoidant personality disorder is also interesting, can be confused. Yep. But these are people who are socially inhibited and very sensitive to criticism. And so they feel inadequate and they only become involved if they're sure that they're going to be accepted, which is very different than the problems with social reciprocity that you see in autism spectrum disorder. So I just want to make that comment.
Well, but I think, Sarah, that's an excellent point. And that's where, I think it's incredibly important to see people at least twice in doing an assessment. In part because of that particular problem with some people, that seeing somebody for a second time isn't necessarily going to get somebody with significant social anxiety to warm up a lot, but it might help them to warm up a little bit. And I think that can make a significant difference, but also spending time with the child. And I think that's one of the problems that especially, I think primary care physicians and pediatricians they don't get paid in the same way. And so I think don't necessarily have the same amount of time to spend with the child, playing and things always. And I think that creates problems.
For sure. Mm-hmm. Yeah, but thank you. Great morning.
Oh, thanks, Senator.
Thank you, Dr. Nicolson. Dr. Veerakumar has to leave. Dr. Veerakumar, go ahead and ask you. Oh, Dr. Veerakumar, if you want to go ahead and ask your question.
Okay, there should be no echo now. Just a quick comment because we are running out of time. Two great pieces of advice that I got from Dr. Nicolson during the time in the clinic was there are autism. I don't know if you said this or not, but I certainly took away that autism spectrum disorder appears to me at least a set of yet to be characterized neurological findings. You should be able to see some evidence on the mental status exam and not just get things from the history. And I find a lot of the misdiagnoses are from the history perspective.
Yep. Absolutely. And I think studies have shown that on paper, it's not adequate. That there is no substitute for good clinical observation and good clinical skills.
Yeah. And the other thing I learned was you should date all psychotherapy modalities and marry none of them. But that also means not neglecting psychodynamics out of hand. And I think there are a lot of great theories in object relations, specifically about identity diffusion, which can readily cut through some of the haze surrounding the late onset, like the adolescent self-identifying with autism later on, and also will allow some entries for therapy, even if they seem to be resisting all care except those for autism. So those are the last things I wanted to say.
Thank you, Ashan. And in fact, it was Dr. Julie Richard who first brought to my attention the psychodynamic theories of autism. And in particular, I believe, Julie, we had talked about a woman by the name of Frances Tustin years ago. and her theories about liquefaction and autism in classical autistic people.
Thank you, Dr. Veerakumar and Dr. Nicolson. I'm going to take, because it's 10:30 a.m., we're going to stop. We do have lots of questions, Dr. Nicolson, and if it's okay with you, if you can stay and we can record the answers to those questions, if you have a few more minutes.
Sure.
But I'm going to formally bring today's event to a close. So on behalf of our entire audience, and we've had lots and lots of participants, upward of almost 130 participants. So that's a huge number that is interested in this patient population. So please join me in a very robust and excellent round of virtual applause for an excellent presentation for both Dr. Nicolson and Dr. Veerakumar. Thank you very much. We really appreciated it. And if you can stay online, Dr. Nicolson,
Yep.
I can read out the questions. And if you want to give your answers, then at least we can have that
Sure.
completed
So I
as
think,
part of the
Verinda,
recording.
though, instead of
If that's
clapping,
okay
so I
with
think
you.
what is encouraged at many autism conferences now because of noise sensitivity is to
Okay.
actually go like this and wave your hands. So instead of, we need a new emoji for waving your hands like this instead of clapping like Dr. Richard is doing right now. And I think I stunned Verinda into silence there.
Yeah, that's good, Dr. Nicolson.
Sorry, I somehow got kicked out of the thing. So do you want me to read or you want to read them yourself? I think it's probably easier if I read and you can answer them.
Sure. Yep.
Is that okay?
Yeah.
Okay, so Dr. Jerome has two questions. Do you think that comorbidity with ADHD and ASD is underdiagnosed?
Sorry, say
How
that
well
again?
do stimulants help ASD children with comorbid ADHD?
So with regards to the second question, hi, Lawrence, the studies have shown that they can be effective. They're just not as effective, and they're not as consistently sort of day-to-day effective in sort of large multi-center placebo-controlled trials. And I think there's also a greater number of mood side effects, sort of irritability and things in people with autism. But certainly, you know, I find for some people, particularly the higher functioning kids, I think they can be really helpful. I think the problem is the lower you go in IQ, the less effective they become, which I think is a sort of a finding that people have talked about for years and years. And the first question that Lawrence had. Verinda, I forget the first question that Lawrence had.
So the full question was, do you think that comorbidity with ADHD and ASD is under or undiagnosed, I think is
Underdiagnosed.
Underdiagnosed.
Well,
Yeah.
so I mean, it's an interesting question because in DSM-3 and I believe in DSM-4, there was actually a statement that if people had a diagnosis of autism, they could not be given a diagnosis of ADHD. The idea being that the ADHD symptoms were accounted for by autism, which may well be true. But one of the purposes of a diagnosis is communication and to guide treatment. And I think if somebody is really overactive, so Niren Sukumar and I saw a boy yesterday who was, frankly, after half an hour with him, I was exhausted. And I think Niren was too. And it, you know, I think in kids like that, I think that the diagnosis is often overlooked, but it may be very, I mean, that's really in a lot of ways what this boy, I think for him, the most impairing symptom is the ADHD stuff. So yes, at the same time, I think, you know, Lawrence, there's been a lot written in the last few years about the overlap with autism and ADHD and on paper, but I think the ADHD symptoms that we see in people with autism, I think they're very similar to classic ADHD on paper, but I don't think it's necessarily the same. I think it's a lot more aimless wandering and, you know, and this boy yesterday, you know, he was 7 or 8, but functions probably like a 1.5-year-old. And so developmentally, he was literally climbing on furniture, was turning over couches and things like that. And so I think on paper, it's ADHD. I'm just not sure it's the exact same thing though.
Mm-hmm. Thank you. Leanne Davidson has a question. Thoughts? Been having interesting conversations with my 11-year-old regarding increase in childhood diagnosis. He will ask, why does Jane Doe in my class have autism? I don't get it. He said something recently that resonated. Mom, Kids are weird. It's our time to be weird. You guys overthink us too much.
There you go. Out of the mouths of babes, as they say. But it's true. And I wonder if, though, I think with, again, societal change and things, I wonder if there's less willingness on the part of parents to accept the fact that their child is just odd or different, that there has to be an explanation for it.
Yeah, okay. Dr. Curry, a great talk. Every now and then, I find myself reminded of the limitations of the DSM. The changing criteria and history was surprising to me. Where do you land on the quote unquote true ASD diagnosis as you stated it?
Well, the true diagnosis is whatever I say is what I think. But no, I mean, I think, that's a really interesting question. And I guess at some level, and I hate to say this, but I am almost like Antonin Scalia and Clarence Thomas, and almost an originalist. I go back to what Leo Kanner defined. And I think that original description of a group of kids were fairly easy to recognize and fairly obvious. And in my mind, that's what autism really is. I think that it has become, I think it's become really diluted. And I, at the same time, I'm not naive. I mean, the horse is out of the barn. I mean, we can't put it back in, unfortunately.
All right. Next question is from Carrie Stevenson Lim. Can you comment if there are any connections between feeding, eating issues, for example, selective eaters and autism?
So I think that it guess depends upon what the question is asking. So if it is about, is there a relationship? For sure. I think we know that children with autism are much more likely to be picky eaters. And this is a huge problem. And I don't know whether it's taste or texture or what it is, but I've got, several patients, not many, less than 5, but who are 7 and 8 and still drinking out of bottles because they won't eat solid food. Their parents have done everything and they will not eat solid foods. And so I think there is a relationship. Why that is, I don't know, but certainly it's been well described, I think.
All right. Thank you. Next is Dr. Bilal Salem. Any increase in the rates of substance use disorders, special choice of certain substances such as THC or stimulants in patients with ASD?
So keep in mind that I am a child, well, actually, I can't call myself a child and adolescent psychiatrist. I'm a psychiatrist who works with children and adolescents. But I think that the group of people that I see for a living tend to be fairly disabled. And I have not seen a lot of kids with what I believe is autism get into problems with substance use over the years, just because I think that they are not, I don't know how to say it in a polite way. I don't think they're able to get into trouble with them because even buying drugs requires some social skills. So, I mean, not that I've seen, however, I think it's been reported in adults who are more mildly affected that they would have some problems with substance use. I'm just not sure of what the literature actually shows, to be honest with you.
Okay. And Dr. Bertoldi has a question. I have a family with 4 out of 8 kids with ASD, poor mom. Then I met dad who looked over my shoulder to the side at the floor, anywhere not to make eye contact, and maybe made very stilted conversations and was stimming, hand flapping. So she's just talking about a patient of hers. Then, and maybe you might want to comment on that. Yeah.
Yep. So I think that's where I don't think, for what I do, I think family history is of some value, but not always a lot. But I think where it is really interesting is we know that in some family members of people with autism, particularly fathers more often than mothers, we have sort of what's called the broader autism phenotype. So attenuated forms of autism, essentially. So people with those sort of social difficulties or communication problems. And I'm not sure it makes any difference in terms of diagnosis. Maybe it does, but certainly it helps, I think, in understanding families and figuring out how we're going to work with them and how we're going to communicate in a way that people are going to understand, but also feel that they can be heard.
All right, thank you. Dr. Jerome's question is, what do you think about research diagnostic criteria approach versus DSM approach?
I don't know enough to comment, to be honest with you, Lawrence. What are your thoughts about that approach and the differences?
I'm not sure whether Dr. Jerome, are you here? Do you want to maybe?
He is here and I've allowed him to talk.
Hello.
Oh, hi, Lawrence, how are you?
Hi, Rob. Good to hear you. Great talk. My question was really, I guess, stimulated by the idea that the research diagnostic criteria approach is trying to look at underlying biological mechanisms, maybe. and define that rather than symptoms. We do know that the correlation between symptoms and impairment is low. And I think what we try and treat is impairment, not symptoms. So that's what drove my question. Because
but do you think that's, I mean, do you think in ADHD we're treating the impairment?
Great question. That's what I think I tried to treat, actually.
Well, and certainly, you know, what I would say, Lawrence, I think that if people, well, first of all, if there's no impairment, there's no disorder.
Right.
But also, I think people who are less severely impaired are probably going to get less treatment because, I mean, I think ultimately you're right. We look at how much these things interfere with a person's functioning.
Yeah.
Yeah. So I mean, I would absolutely agree. But the RDoc was Tom Insel's thing at the NIH, looking more at sort of dimensional stuff.
Yes. Yes.
I don't know enough about it, to be honest. I mean, it seems to me the history of medicine is that you either have something or you don't. But it's, and actually I was saying this to a resident yesterday, because I think when we look at people with classic autism, and you know, if I offend somebody, I apologize ahead of time. It's not my intent, etc. But you know, I think when we look at people with classic autism, we could talk about an autism spectrum and a continuum. I'm not sure I'm on the same continuum as people with classic autism. I think their experience of life, their view of the world is very, very, very different from mine. And I'm not sure it is a continuum.
Okay.
But that's only my opinion. And
Thank you, Dr. Jerome. And your next comment is, I think, already relevant to what you've already discussed. So I won't talk about it. Tina has a question. Speaking of the transition to adult care from pediatrics, it sounds as if the system does a decent job of supporting our ASD kids, but do you think it helps them develop adequate skills? How would you suggest that we advocate for improving helping out kids learn skills so they will function better once the pediatric support ends? Thank you for a great presentation.
So I mean, that's an excellent question. And I think that what I say to most parents, you know, when their kids get to high school, I would hope that, again, many people with more classic autism or significant intellectual impairments would do a lot of work preparation stuff, right? A lot of co-ops, looking at what job skills they have, what they need, and what they're good at, what they enjoy. The problem is all those things require supervision, and there's not enough school personnel always to supervise them. And so sometimes people do co-ops in the school, which isn't really the same thing. And I just think there's not enough opportunities for those kind of job placements in schools. And I think that's one thing that would really help a lot.
Okay. And Dr. Elizabeth Roach-Fox has a question. Hi again. Curious about your approach to the growing negative perceptions of ABA, thanks to testimonials from adults who received this as children. Does this come up in your discussions about treatment? And if so, how are you broaching this topic?
So, yeah, I mean, that's an interesting question, Elizabeth. And there's actually, so when the government, back in around 2000, when the government of Ontario introduced the IBI program, and I think the government of Canada, there was some laws, I don't know what, but Michelle Dawson, who works with Laurent Motron in Montreal, and she has a diagnosis of autism. She actually was part of a group of people who, I don't know how I ended up in the Supreme Court of Canada, but they were actually, or with the government, but they were saying that it shouldn't be used because it's barbaric and things like that. But really, when we think about it, everything we learn in life is probably through ABA at some level, right? It's just a matter of, well, I don't want to oversimplify it, but it's rewards and consequences, and it's how we learn everything. So I don't know what the backlash can be. I think in the past, there was more of an emphasis on punishment, I think. And I think one of the criticisms of IBI in the past was, especially when it was done at tabletop, was that it teaches children to do what they're told, not to think for themselves. And I think there was also some, corporal punishment. I had a couple of patients who actually saw Ivor Lovász at UCLA, so the person who started the idea of early intervention in people with autism. And one of the moms told me that Lovász told her, to keep a wooden spoon handy, and the kid got out of line, not, just to reach over and wrap his knuckles with a wooden spoon, which I don't know how well that recommendation would fly now. I don't think it would very well, but I think people who are against the idea of ABA are perhaps not understanding what it means in total. Because I've also heard parents say, ABA doesn't work, but logically that statement doesn't make any sense. That it may be that particular program hasn't worked, but again, we learn everything through rewards and consequences. Even, as Virendra's talking, you could say that she's doing ABA on me because she's nodding her head and saying, oh, so she agrees, I'm going to continue to ramble on. But I mean, everything we do, I think, in life is, at least for most people, is based upon those kind of constructs.
All right. The last question is from the chat, Dr. Ross, and I did say to him in the chat, he had to leave, that I will ask this question of you. He says, please could you comment on what distinguishes the restricted and fixated interests and behavior patterns in ASD versus quote unquote regular, particularly in young adults? Patients self-diagnosing with ASD more likely with social anxiety, PD, ADHD have reported restricted interests to me that were not particularly odd or obsessive in quality, but it is hard to know how to assess these.
You know, I mean, that's an excellent point that James made. And there's a lot of research on, you know, sensory abnormalities in people with autism and on repetitive movements and on ritualistic behavior. There's very, very little written about the unusual interests that we think of in people with autism and what makes them unusual. And so it's a difficult question to answer. I think that they become all-encompassing at some level. And although in DSM-4, I think it said you can have, you know, one or more all-encompassing interests, but I don't know how you can have more than one all-encompassing interest, because if there's more than one, by definition, it's not all-encompassing. But it's, I think that what's different is the fact that things, and this is what Catherine Lord has talked about, that, you know, the interests don't change over time, they're not used socially, and they don't necessarily have any functional purpose to them. So I had a patient years ago, and he was really interested in the stock market. He was like, he loved watching the business channels where they would have the stock tickers across the bottom. And I hate to say it, but I thought to myself, this is fantastic. This kid is a savant of some kind. He's going to tell me what stock to buy, and I'm going to be wealthy beyond my wildest dreams. Unfortunately, when I asked him about it, he was saying, yeah, he really liked it. And I asked him, do you know what those numbers mean? And he said, no, I just like watching them go across the screen. And so, first of all, my heart was a bit broken. But I think it's also the, I think that the difference is that there's not a lot of, they're not used socially. They don't tend to have a lot of function or purpose, and they don't change over time. But that's a gross generalization. So in Leo Kanner, he had 11 patients that he described in 1943. And among them, he did a follow-up study years later. And, you know, in general, their outcome was terrible, mostly because nobody knew what to do. And they ended up on the back wards of mental hospitals. But two people, one in particular, the very first kid he described, a guy by the name of Donald, and he had a phenomenal.
I can't hear you now, Rob.
I can hear myself, I think.
Yeah, you're good. You're good. Keep talking.
But but this guy, Donald Triplett, he had an incredible ability to do math in his head. And he lived in a very small town where everybody knew him, that he was a bit eccentric, as they would have said back then. And he ended up working in a bank. And so he actually did very well because they were able to use his unique skills and interests to help him find a job and find work. And so I think in those ways they can be helpful, but I don't know if most people that we see have those kind of interests that can be used for some kind of greater purpose.
Oh, you're muted.
Who, me?
No, Dr. Dewar.
That brings us to the end of today's presentation. Thank you, Dr. Nicolson, for staying back and answering some of these questions. Thanks a lot. It was awesome. We really enjoyed it. And there was quite a few number of participants also who stayed back to listen to your answers. So
I would do anything for you, Verinder. So I'm glad that you helped. But no,
okay, thank you.
And I think the discussion was
it was awesome. We really enjoyed it.
Good.